I'm Dr. Jagmeet Madan. I'm the National President, Indian Dietetic Association, and I'm also the Principal Professor, Sir Vittal Das Thackeray College of Home Science, SNDT Women's University, Mumbai. I bring greetings to you from the IDA and SVT College, which is one of the very eminent institution and the first autonomous college in the state of Maharashtra, and celebrating its 25th year of autonomy. So friends, today I am going to talk to you on a very relevant topic, which I think every nutritionist should be enlightened on, and that is nutritional strategy for diabetics in COVID-19. Why is it that we feel that this topic is very relevant in present times? Because ever since this pandemic has struck us, ever since we've gone into a lockdown from March 3rd week, we have entered into a condition wherein meeting nutritional needs has become a key challenge. And I'll try to set the context. India already has a triple burden of malnutrition. On one side, we have gross undernutrition. On the other side, we have gross overnutrition, obesity, and we also have hidden hunger. But what is alarming is also that we have people with normal BMI or low BMI, but yet carrying a high amount of body fat. Now remember friends, the moment we accumulate fat in the body, it sets the whole story of inflammatory environment within the body. So what I'm talking about is a state of lean obesity, which is very peculiar to India. And this lean obesity basically relates to the inflammatory environment which every Indian is carrying today within. So to look at, you may be normal, but your body composition tells us what is your body fat percentage, what is your muscle mass, and what kind of level of inflammation you are carrying. And majority of Indians have higher amount of body fat with low BMI, and also they have low level of muscle mass, and that's what we refer to as sarcopenia. So this is not a very happy state of the body, and the recent researchers have shown that COVID is striking more to people who are overweight, obese, and I would go one step, it is also striking people who may be lean but are carrying a very unhealthy body composition with more body fat and less muscle mass. So what exactly is happening? This is pushing us to more and more comorbid conditions, and as we see the higher incidence of pre-diabetes, diabetes, hypertension, hyperlipidemia, it's like synonymous. Every second person you hear having this kind of comorbid condition, and this lethal combination of inflammation within the body and the comorbid condition has actually compromised our immunity to a great extent. And that's why we are, becoming prey to this infection very, very rampantly. And, it is like a vicious cycle which we have to break, and we have to come out of it. So why do I say that meeting nutritional needs is a challenge in COVID-19 times? Because let's accept it that today with the lockdown, we are confined to a certain environment. We have to practice physical distancing. We have to follow certain norms which are expected for us to beat this pandemic. So this has brought us to a state where we may be having limited resources. We are also having financial insecurity. There are changes in food supply in agriculture. There is limited access to fresh foods. There is increased consumption of convenience and processed food. There is limited support systems. There are altered home environment. Within the same house, there are 3 to 4 people working from home, needing their space. So the challenges are different. And at the end of the day, we have to look at the need of all the members of the family. And so that is where needs of the young children become important, needs of the elderly become important, and especially, I would say, need of people with comorbid conditions, especially diabetes or cardiovascular disease, becomes very, very important. So our focus today is going to be diabetes management with the backdrop of COVID-19, right? Now, what are the key components? It could be any diabetes. It could be type 1, it could be type 2, it could be gestational. These are the 4 pillars, which are the key components of diabetes management. So first is a healthful dietary pattern, which is the most important thing. Second, regular physical activity. Third, pharmacotherapy. When I say pharmacotherapy, it could be your oral hypoglycemic drugs, or it could be your insulin, or a combination of the two. And fourth pillar is the constant monitoring. Now, once we've understood this, then let's go further to look at what the recommendations of American Diabetes Association are in present times. Now, the latest recommendations of ADA completely and clearly gives us a direction that diabetic individuals are very different. Okay, and when we even define diabetes, we say that it is a syndrome, and syndrome means it will manifest in different individuals in different ways, which means there is no one size which fits all for diabetic. Okay, so it is very, very important that we need to customize the nutrition therapy to the need of the diabetic person who is in focus. And it goes without saying that in the diabetes management, the proactive involvement of the diabetic is very, very important. So self-management, education, treatment planning with the healthcare provider becomes imperative. And I must emphasize, there has to be a collaborative development of an individualized eating plan. And what we emphasize based on these recommendations is that there should be total patient management approach. So all aspects of patient management have to be taken into consideration, and that's only possible when we work as a healthcare team which is knowledgeable, which is fully equipped, updated, and provides that kind of support to the diabetic person. So what are the goals of nutrition therapy? First, to promote and support healthful eating pattern. 2, to attain individualized glycemic control, blood pressure control, lipid goals. Why we say especially these 3? Because these are the most important comorbid conditions which the diabetic person is likely to suffer. Then, achieving and maintaining body weight goals, delay or prevent complications of diabetes, address individual nutrition needs. Like I said, each diabetic would present with different permutations and combinations, and depending on what the case profile is, your priority in terms of nutrition needs can be different. Then at the end of the day, we have to understand that a diabetic also has to live a very fulfilling and productive life. So eating still has to remain a pleasure, and eating will become pleasure only when a nutritionist does a hand holding with a diabetic and gives him the flexibility, gives the kind of food choices from where the diabetic person can pick, and there is no monotony, there is a lot of pleasure even in following that eating or dietary pattern. And in addition to that, the team has to again empower the individual with the diabetes practical tools in terms of whether it is monitoring of blood glucose, whether it is carbohydrate counting, whatever it takes for the self-empowerment of the patient or of the diabetic person to manage himself very well. Let me just summarize and say one statement, that one message which as a nutritionist you have to give to your diabetic person or diabetic patient is that under all circumstances, whatever it takes, we have to commit towards maintaining our glycemic control, monitoring our glycemic control, because the moment we do this, we can impede, all these associated comorbid conditions. Now, why is it that, it is such a challenge to handle diabetics in India? Remember, diabetes is a metabolic disorder where the nutrient which gets impacted is carbohydrate. That means body is in a state that body cannot metabolize carbohydrate adequately. Okay, so whether it is the insulin insufficiency or insulin inefficiency, whatever be the cause, but the major nutrient which gets impacted is carbohydrate. And the ironical situation is that Indians are carb people. So Indians cannot give away their carbohydrate. So it's very hard to convey to the diabetics that carbohydrate for you is not a free food. Carbohydrate for you is a rationed food. And when we say rationed food, means you really need to define the quantity of carbohydrate for the diabetic, keeping in mind the total energy intake which is needed by the person depending on his age, sex, frame, physical activity, and whatever physiological state he is in. But the recent study clearly shows that, the START study, which is a very known study in India, clearly indicated that on an average, across India, the carbohydrate contributes to about close to 60 to 65% of the calories, and, when we look at the data for carbohydrate intake of type 2 diabetes mellitus patients or people, we find that they also have a very high percentage of their calories coming from carbohydrate. So this is one of the reasons why, we find it very challenging to address diabetes in India. Now, what has happened in COVID-19? That we are confined to home, and with the confinement of the premise and the limited availability of food choices, and if we are not empowered to know what is it that we need to emphasize and what is it that we need to ration, somewhere the carbohydrate increase is going higher, and that also specifically the refined carbohydrate intake, because a lot of dependence on ready to eat foods, ready to eat meals. So there is kind of, indirectly increase in the refined carbohydrate consumption. So that's becoming another challenging factor to control diabetes in COVID-19 conditions. And of course, it goes without saying, Indians and Indian cuisine is known for its sweets, the Indian sweets, and Indians are the largest consumers of sweetened food items. So if this is the backdrop in which we have to discuss the management of diabetes, I think the story has to begin by starting with the caloric intake. So the first message which needs to go to a diabetic person is that your caloric intake needs to be defined as per your age, as per your sex, as per your frame, as per your level of physical activity, so that you have to define that this is the framework within which I have to get my nourishment. It is very clearly indicated that for an obese person, we look at 20 kilocal per kg ideal body weight, and for a non-obese patient, we can consider 22 to 25 kilocal per kg ideal body weight. Now, how do you calculate ideal body weight? I'm sure all of us know that there is a very standardized and a simple way of calculating ideal body weight, and that's called Broca's index, which just tells you convert your height into centimeters, subtract 100 from that, and whatever figure you get, that's your ideal body weight. So that's for males, and for females, you subtract 105. So for instance, an average Indian man with 165 centimeter height should ideally weigh close to 62 kgs and should require about 1850 kilocalories to maintain a healthy weight, assuming that the person is leading a sedentary lifestyle. Another thing which we have to convey, so one is a defined caloric intake which has to be individualized. That's the first message regarding caloric intake. The second message is that there is no concept of fasting and feasting when we are managing diabetes. So we can't say, okay, I will not have any meal today and I'll have only dinner, or I'll have only breakfast and I'll not eat the whole day. I think this kind of liberty a diabetic should not be taking, because it's going to disturb the glycemic control. So ideally, a defined caloric intake, which should be very well distributed in the three major meals, that is breakfast, lunch, and dinner, and an evening snack. These are the basic format which a diabetic, especially type 2 diabetic, should follow. Why I'm saying type 2 diabetic? Because for type 1 diabetic, depending on the insulin dose and the kind of insulin the person is taking, there can be a little variation. But in totality, we would say that we should encourage the diabetics to take at least 4 meals in a day with more or less, defined timings. There could be an allowance of half an hour here and there, but as much as possible, if we can discipline ourselves to take our 4 important meals at a defined time, it will help us control our sugars better. So let's look at now the macronutrients. So first is, of course, carbohydrates. Now, for a diabetic, I think we would be happy to keep the diabetic around 50% of the total caloric intake so far as carbohydrates are concerned. Okay, even if we can achieve less than 50, very good. But then, I would be happy that if they are 50 or little less than 50, rather than moving towards the 60 or plus 60 plus. Now, second is one is the quantity of carbohydrates. So 3 things very important. 1, the quantity of carbohydrate. 2 is the quality of carbohydrate. So that's where we definitely emphasize a lot of complex carbohydrates. And when we say complex carbohydrates, we are looking at a lot of dietary fiber coming with the carbohydrate source. So we are looking at whole grains, we are looking at millets, because they inherently contain a whole lot of fiber. And not only fiber, they also add a lot to micronutrients, a lot of phytochemicals which come through them, good quality fat. So it's a bundle of nutrients which you get from them. But in spite of that, it goes without saying, carbohydrate, even good quality carbohydrate, still remains a rationed food for a diabetic. Third is the distribution of carbohydrate throughout the day, which is very important. And that's where I said that we need to divide our carbohydrate equally between our three important meals. That's our breakfast, lunch, and dinner. And some amount of carbohydrate should be kept for snack time. And if we are taking any medication post dinner, maybe a little bit can be kept even for bedtime. But so this distribution is very, very important. So again, I repeat, it's the quantity, it's the quality, and it's the distribution of carbohydrate throughout the day, which is very, very important. Lot of emphasis on dietary fiber coming with the carbohydrate source, besides what else you can add as fiber in your diet. There is no place for refined carbohydrates in a diabetic diet. As much as possible, do away with the maida, the rumali roti, the breads, the bakery products as much as possible, because they are completely devoid of fiber and they are going to increase your blood sugar levels, which can damage your glycemic control. And another important point about carbohydrate is that there is an absolute no-no to fruit juices or aerated beverages or sugar syrup-based beverages for diabetics. So today, why diabetic? I think for every Indian, because all of us are sitting on the edge of becoming a pre-diabetic or qualifying to be a diabetic, I think we should be wary of all HFSS foods. You know what is HFSS? High fat, salt, sugar foods. So all sugary, items, drinks, sugary preparations, which are snacks or refined maida-based preparations, they need to be cut down in a diabetic diet. Now, I must talk a little bit about dietary fiber, because this is something which is the essence of planning a good diet for a diabetic. So we have to give this very strong message to a diabetic that whichever meal you are consuming, see to it that you get your dietary fiber in that meal. And in totality for the day, you should be consuming, if you are on a 2000 calorie diet, you should be minimum consuming 30 grams of dietary fiber. So what is this dietary fiber doing? This dietary fiber is basically helping us to, prevent the spikes in the blood sugar. It is helping us, create a good substrate in the gut to favor good microflora, and indirectly it is impacting a good metabolic health in the body and preventing the comorbidities to come in the life of a diabetic. So as nutritionists, we need to understand the dietary fiber a little more. So the dietary fiber can be of two types, soluble or insoluble. Soluble dietary fiber includes inulin, pectins, beta-glucans, and this is something very, very important for a diabetic because they have a hypoglycemic effect, they have a hypocholesterolemic effect, and you know that beta-glucans are immensely present in oats, barley. These are all very rich sources of beta-glucans. Pectins are very much there in your fruits, especially something like apple, something like guava, okay, your beans, your gawar, vegetables so all these vegetables are rich in soluble fiber. Then besides this, something like, your inulin is also there in raw banana. It also has resistant starch. So it's adding to your total fiber intake. That is soluble fiber. Something like lady's finger, even pulses for that matter, also give you a good amount of soluble fiber. And in addition to that, they also have certain phytochemicals which decrease your blood sugars. The insoluble fiber, the examples, of course, here are given like any vegetable, whole fruit, brown rice or millets. These are all examples for insoluble fiber, and there's no food which will only have insoluble fiber or soluble fiber. A natural food will have both, but there will be predominance of one kind of dietary fiber more in a given food. So like I said, the functional roles are very important. Decrease in postprandial glucose response. It impacts the lipid profile. It decreases the gastric emptying. It improves the insulin sensitivity. It also helps in developing a good microflora. So this is just to give you a snapshot of what kind of foods should you be incorporating. This is just to give you the total dietary fiber content of different foods. So what tops the chart is your pulses. And I think as Indians, we have always undermined the importance of pulses. We have such variety of pulses that if I start eating today, next 15 days, I would not repeat a pulse or a dal. And whether it is a dal or whether it is a pulse, they all give you good amount of total dietary fiber. And like I said, especially, good amount of soluble fiber, which is there in pulses. Now, the second group which really tops the chart in dietary fiber is your nuts and oil seeds. And today, nuts and oil seeds are really valued in a diabetic diet because they are not only fibrous, but they give you good quality fat. And today, replacing carbohydrates with good quality fat is the mandate for decreasing, the spikes in the blood sugar, getting better control on the sugars, getting benefits in lipid control, getting a more anti-inflammatory environment in the body, getting a whole lot of important vitamins and minerals which are cardioprotective. I think these are all the benefits which we are getting from nuts and oil seeds, and easily. I mean, we have recently done a randomized control trial with almonds where we've used 56 grams of almonds. Of course, not in type 2 diabetics, but in adolescents and young adults, starting from 16 years to 25 years. But majority of them, more than 30%, were pre-diabetics. But even with substitution of their snacks by nuts, we could see a change in their lipid profile. We could see a change in the, decrease in the inflammatory markers. So these are all the benefits which we are getting from the nuts. And then after nuts is your vegetables, whole vegetables, which are local, colorful, seasonal. I think these are all the things to be emphasized in the diet, and a mandate which you must give to a diabetic is that both your important meals, whether it's lunch or dinner, should have a big bowl of salad. Your meal has to start with fiber. So in fact, the recent studies also tell us that it's not only, how much you eat, but what you eat first. So when it comes to fiber, a bowl of salad, or a half plate filled with vegetables. So first you start with your fiber, first you start with your salad, then you come on your proteins, and then you come on your carbohydrates. So if you follow that order, I think you are helping about your body not only in terms of the nutrient density, but even in terms of very good glycemic control. So then you have the vegetables. Now even some roots and tubers can be consumed, but again, rationed amount, because they have a lot of starch in it. But some of the roots and tubers have a low GI, like sweet potato, but you need to kind of quantify them, how much you need to incorporate in your diet. Similarly, fruits, when we talk of fruits for a diabetic, I think on a scale of 100, the emphasis on fruit is only 30% or 40%. The remaining 60 to 70% emphasis is on vegetables, right? So these are important messages which we need to give to our diabetic persons. Now, the next concept which really needs to be embedded in our understanding is that for a diabetic, These two words are very important. One is the glycemic index and the other is glycemic load. So what is glycemic index? So a glycemic index is a measure that how much a standard quantity of food raises your blood sugar compared to a standard quantity of glucose or white bread. So glucose or white bread, the spike would be 100%. So in analogy to that 100%, consumption of an X amount, the equivalent amount of carbohydrate, what kind of spike is it causing in your blood sugars? That's very, very important. And that is what is glycemic index. So what is high GI? If the spike is 70 or more than that, then you will classify that food as high GI. If it is 56 to 69, medium GI, less than 55, low GI. So you have all kinds of foods which are there, which can be categorized into these three, and there are glycemic index tables which are available. It's a very, very scientifically done testing, and it is published for different variety of foods. Even in India now we have data for the GI content of foods and food preparations. We have Dr. Mohan's Diet Atlas, which also gives a whole lot of data on the GI content of different foods and food preparations. Now, in addition to that, we need to understand that there are certain factors that influence the glycemic response. So, what are the factors? First is type of starch. So, even though, when we say that pulses contain starch, so I give you an example, one medium-sized potato, one bowl of rice, 2 slices of bread, 1 chapati, half bhakri, each one of them give you 20 grams of carbohydrate. They are all complex carbohydrates, but the rise in blood sugar caused by the bread is the highest, then comes potato, then comes your chapati, then comes your rice, then comes your bhakri, and then comes your pulses. So why is there so much difference? Because the type of starch differs. Now pulses are known to contain resistant starch in very, very good amount. Now this resistant starch blunts the glycemic response. Physical entrapment, that means the moment you process a pulse or a cereal, you convert the whole pulse into a pulse flour, the glycemic response will increase. The moment you germinate a pulse, the glycemic response will increase because the complex starch has got converted into simple sugar. The moment you ferment a cereal pulse combination, the glycemic response would increase. So, you may say dhokla, idli, they're very, very healthy options, because they are steamed, right? They are steamed, so they don't have fat, but they have high glycemic index. So they need to be still quantified for a diabetic, because if you consume, dhokla or idli or these kind of products wherein we have processed the starch to a great extent and we consume them in larger amounts thinking that they are not containing any fat, somewhere we are damaging the blood sugar control. So the processing of these cereal or the preparation is very important. Then viscosity of fiber. So that's where now when we make idlis, when we make dosas, we are not only using rice and dal. We try to use a combination of cereals. We try to add barley. We try to add oats. We try to add methi seeds. Why? Because this is going to increase the viscosity of the batter, which is going to be used to make the preparation. And that's going to help and blunt the glycemic response. Similarly, there are certain foods which are high in protein. So anytime when we are combining a carbohydrate with protein, if the proportion of protein is higher as compared to carbohydrates, the total glycemic response of that meal is blunted, right? Similarly, the glycemic response of curds, milk and milk product is lower. So it's always a good idea that if I'm consuming rice, I consume it in defined quantity, I support it with a good bowl of pulse and a good bowl of curd and a bowl of salad. So in totality, the glycemic response of this meal will be much, much lower. And I can become more intelligent by first consuming my salad, then consuming my dal, and then coming to my rice towards the end. So these are some of the ways by which we can really control the glycemic response of the meal. And why it's important, because remember, it is the postprandial increase in the glycemic response which favors hypertriglyceridemia. So the more we control the spikes in the sugars, we prevent insulin resistance, we prevent hyperinsulinemia, we prevent hypertriglyceridemia, and we get a good metabolic control. Now, coming to the glycemic load. So it's very important to connect the two terms. What is glycemic load? It's the amount of carbohydrate in a food, or overall diet, which impacts the total contribution of the carbohydrate of that food in the total diet. So the glycemic load is the product of the glycemic index of a food item and the available carbohydrate content of that item. So which means, say for example, if I'm looking at papaya as a fruit, the total amount of carbohydrate per 100 gram of papaya may be less. So the glycemic load is less, but the glycemic index of papaya is high. Similarly, if I'm looking at carrots, the glycemic index is high, but the glycemic load is low. So how do we connect the two? What is low for glycemic load? Anything which is less than 10 grams of carbohydrate is a low glycemic load. Anything which is 11 to 19 is a medium, and anything above 20 or more per serve, like whatever amount you're consuming, is a high glycemic load. So what do we want? We want those food choices for diabetics which are low in glycemic load and low in glycemic index. So when will that happen? When we'll have those food items which are fibrous, which have less carbohydrates, and we use it in such combinations that in totality our carbohydrate load in that meal is controlled and even the glycemic response is less. So both the things are very important. Like I gave you the example of papaya. So if papaya is having low glycemic load, that doesn't mean that we sit with a big bowl of papaya and eat it, that because it has very less calories, because it has very less amount of carbohydrate, but it is having a high glycemic index. So if I'm overdoing on papaya, I'm somewhere spiking my sugars, which is not a good idea. So it's better to consume a fruit, say something like apple, something like guava, with skin, so that I get the fiber, there is a lot of pectin there, so, and the glycemic load is also less. So both I get the advantage of low glycemic load and less glycemic index or low spike in the blood sugars after I consume. Now, why are we talking about glycemic index and glycemic load? Because there is huge amount of data to show that if we substitute low glycemic index foods for higher glycemic load foods, it modestly improves the glycemic control. And there are studies to show that just by altering our food choices, going for low glycemic index eating pattern demonstrates a reduction in glycosylated hemoglobin. So that was carbohydrate. Just to recap, carbohydrates are rationed macronutrients. Quantity is important, quality is important, distribution is important. Carbohydrate with fibers need to be valued. Dietary fiber is important for a diabetic diet. Resistant starch-rich sources are important. And we need to have foods which have a low glycemic load and low glycemic index to be emphasized in a diabetic diet.